Hello everyone. Assalamu alaikum wa rahmatullah. Today, inshallah, we will discuss very important topic, very important topic from exam point of view and also in your practice. What about understanding of the precocious puberty in girls? And to be honest with you, usually my advice for all my candidates, if you will face any new scenario in the exam, try to follow the template, try to use your own knowledge and the clinical knowledge from your practice to answer this question. Don't be in panic. And this is my golden advice because sometimes the first station will be the worst or the most difficult one in the exam. So don't let any station to affect the remaining stations in the exam or the remaining tasks in the exam, and just relax and try to use your knowledge. However, in this scenario, exactly the precocious puberty, it's very difficult unless you are working with the endocrinologist or in the multidisciplinary input or team to manage such patients, the precocious puberty in young girls, right? So if you are not practicing this um, topic or these cases in your practice, it will be a little bit difficult in the exam to answer the question. However, you have to try, you have to do your best because it's difficult for everyone. It will not be difficult only for you. And this is my advice now, guys, because as you can see, the RCOG starting now to bring new scenarios, difficult scenarios. Some of the scenarios will be very easy to answer from your practice, like, for example, post-operative complication, hyponatremia, or fever, or injury, or anything, even if it's not the previous exam cases or scenarios, like bleeding or vascular injury, ureteric injury, or bowel injury. If we will have any other new scenario, you can manage from your clinical practice or from your clinical knowledge, right? But in this scenario, as I told you, it's a bit difficult. That's why I decided to discuss it today with all of you. Okay, so let's start. I don't want to waste your time. I'll try to arrange another session for the advice for how to prepare for part 3 and also the technique of the stations, how to go to the exam with self-confidence, how to answer the new scenarios as well, because now it's not guaranteed that all the stations will be from the recalls, and it's a little bit fair, like to find 12 or 13 stations recalls and 1 or 2 new stations. I think it's fair for everyone. Um, let's go and start our discussion today. Before going to any topic, and this is another advice from my side, please just put like learning objectives for yourself, right? If you will go through like a talk article, you will find this learning objectives at the start. Please don't ignore, don't jump to the introduction or what's after that. No, have a look on the learning objectives because it will tell you by the end of this topic what about the like the learning objectives you have to achieve by the end of the study or reading, for example, talk article or any article. So for the precocious puberty, what about the learning objectives here? We need to be aware of the normal development and milestones of the puberty. If we don't know the normal process or the physiology, we will not be able to understand the abnormality or the disease or anything like happened abnormal. To understand the etiology, the diagnostic evaluation of any girl will present you in the clinic with precocious puberty. And also to be aware of the treatment modalities and multidisciplinary management. And here in the precocious puberty, the management should be with multidisciplinary team. You will not be able to manage this case by yourself. In any structured discussion, again, another advice, I'll give you like lots of advice today, but another advice here, in any structured discussion, please start with definition or introduction or both of them. So you can use whatever you have in your knowledge, definition, introduction, or both of them, you can start. So tell the examiner at the start that precocious puberty, it's the development of the secondary sexual characteristics before the age of 8. Very important point, because if this girl or the patient presents to you after age of 8, so this is normal. This is the lower age of the puberty. Usually it's around 10 years, but the lower age is 8. Any development before 8 years, so it's precocious puberty. We can divide it into 3 types: central or gonadotrophin dependent, and from its name, central, so it will depend on the CNS, central nervous system, hypothalamic disease or hypothalamic causes, and pituitary, and or, right? Peripheral or gonadotrophin independent, because it's not dependent on the gonadotrophin, the problem in the estrogen or the hormone secretions from the ovary or the adrenal gland. And here we can give it another name, which is the true precocious puberty, and this one pseudo or false precocious puberty. Or we can have isolated. What is the meaning of isolated? You know that the secondary sexual characteristics, it can be the thelarche, menarche, or puparche, which is the hair, the pubic hair, the breast development, the start of the menstruation or the periods. Sometimes you will find the girl with one only characteristic. For example, she started to have bleeding or menarche, but there is no breast, no pubic hair. And another example, she might present to you with the pubic hair without any other sexual characteristics. So at that time, we will give it the name of isolated, and we will come to this point in detail. So this is the definition, the classification or types, and we will come to that in details like within few minutes. As I told you, give the definition and or introduction. So what about the introduction here? What about your knowledge here, or what should you tell the examiner? What about the incidence, overall incidence? It's around 1 in 5,000 to 1 in 10,000. What about the female to male ratio? As you can see, it's very common in female more than male. It's 10 to 1, female to male. What about the puberty itself? What is the puberty? It's a complex developmental process, begins usually in the late childhood and characterized by 4 things to tell that the patient or the girl that you started now to have, or you start now to have the puberty. The maturation of the hypothalamic pituitary gonadal axis, appearance of the secondary sexual characteristics, acceleration of the growth, and capacity of the fertility. So 4 points we need to fulfill to tell the patient that, yes, this girl started now to have the puberty process. Consequences of precocious puberty. It's part here of the introduction to summarize, like what about the consequences, and also how to investigate, how to treat, and then move forward in detail. So consequences, usually it will be the short adult stature due to premature epiphyseal closure. Usually the closure will happen by the end of the puberty. So when this will happen early, usually this girl will be short stature. Some psychosocial problems, like the self-image, like the girl will feel like she's different from her colleagues. Gonadotrophin releasing hormone analogs, this is the mainstay treatment for the central precocious puberty, right? For the peripheral, it will depend on the cause. As we mentioned, it might be from like maybe because of ovarian problem, because of adrenal problem, because of some medications given. So according to the cause, we will manage. But just to summarize at the start, we might need to give this patient aromatase inhibitors, anti-estrogen, anti-androgens, or tumor resection if the cause is adrenal, for example, adrenal gland malignancy or tumor, ovarian tumor like granulosa cell tumor. If you remember, it's estrogen secreting tumor. So it will lead to precocious puberty. And usually granulosa cell is very common in young age and in old age. And usually this young girl will present with precocious puberty or bleeding. We need to offer this young girl combined consultation with, or just to refer to, pediatric endocrinologist. It's indicated in all cases. And please remember, MDT is mandatory here. And if it's in the exam, MDT here will be communication with the colleagues and also safety point. You will not be able to manage alone. And mention as much as you can. You can mention the pediatrician endocrinologist. You might also involve a pediatrician with a special interest in the precocious puberty, gynecologist with a special interest, technician for the imaging, if you will offer CT, MRI, the laboratory, and don't forget the counselor here. because usually those girls will be affected. Okay, they found that some of the patients with the precocious puberty, it's more with the adopted girl. So that's why it's linked with the psychological problems, and even the precocious puberty also will lead to some psychological or psychosexual problems. To understand the precocious puberty, as I mentioned at the start, we need to understand the normal process. What about the physiology? What happened? And this will lead to the puberty after that. So we have what we name the hypothalamic pituitary gonadal axis. So we have the hypothalamus here in the brain, and also the pituitary, and then the ovary or the testicles. But here we are speaking about the ovary because we are discussing the precocious puberty in the females. So we have axis. We have here gonadotrophin releasing hormone. It will stimulate the pituitary to secrete the FSH and LH, and this in turn will stimulate the ovary. To start, FSH will stimulate the follicle, and the LH will stimulate the corpus luteum to produce the progesterone after that. And FSH will stimulate the follicle to secrete the estrogen. So this is what we name hypothalamic pituitary gonadal axis. So usually what happens, it will start to be functioning when not around the 10 years, no, in fetal life. This is the start. And it will remain active for several months after birth. And then it will be quiet or quiescent for or until the puberty. So is it will start working around the puberty? No. It's active during fetal life, several months after birth, and then it will be quiet until the puberty. What will happen after that? The precise mechanism for this axis to work again, it's still unclear. However, they found that we have like increased amount of the pulsatile gonadotrophin releasing hormone secreted by the hypothalamus. So the process will start from here in pulsating or pulsatile manner. This will lead to stimulation of the FSH and LH from the pituitary, right? So this is the, please remember this word, and it's very important. Sometimes I'm telling the candidates, take care, we have like buzzwords. So for the central, especially the central precocious puberty, hypothalamic pituitary gonadal axis is a buzzword here. We need to use it in the exam. What about this pulsatile secretion of the gonadotrophin releasing hormone? Initially, it will be during sleep only, and then it will progress to be 24 hours secretion. FSH will stimulate the follicle. The follicles will secrete estrogen. After ovulation, the LH will stimulate the corpus luteum to produce the progesterone. So this is the axis and how it will work and when it will work. We have another thing in the puberty process or the physiology of the puberty, what we named Adrenarche. Adrenarche from the adrenal gland. So it's the start working of the adrenal gland. I know it's a bit difficult, this topic, but I'm trying to make it simple for all of you. At any time, if any point not clear, you can just drop the message here in the chat box, or just you can unmute yourself and ask the question, raise your hand, whatever you want, right? Because I know it's difficult, but we will try to make it simple today. So coming back to the adrenarche. So it's the onset of the androgen-dependent signs of the puberty, like pubic hair, axillary hair, changes in the hair and skin to be greasy, to have acne, to have special odor of the adults. And this is because of the adrenocortical activity. And usually it will be before the gonadal, which is the gonadal activation. So usually the adrenarche will start first. Usually it begins between 6 to 8 years, and it will continue until late puberty. That's why it will start before the gonadal activation, right? So this is the adrenarche. What about the clinical stages of the puberty? It's very important. Again, another buzzword here you need to use, which is the Tanner stages. You need to know that we do have 5 stages for the puberty, starting from stage 1 till stage 5. And stage 1, it's the pre-pubertal. Usually you will not find anything. We can name this, we can give another name for stage 1. It's just like the child. without breast budding, without any pubic hair, without any axillary hair, no changes. This is stage 1. Stage 2, this is the actual start of the puberty, usually with the breast, so appearance of the breast buds from stage 2, what we named thelarche, and again, start of the pubic hair. Till stage 5, which will be the adult form. Take care that axillary hair, it will be from stage 1 to stage 3 only. Right? So stage 3, you will find any girl with the axillary hair, so she's in stage 3. Right? I mean the full form of the axillary hair. So axillary hair will not continue thus till stage 5. No, it will be adult form in stage 3. And in this dog article, you will find a very nice picture. You can use, just have a look on it. It's not like mandatory, just showing the changes. Just look here, the stage 1, it's a child, and here stage 5. So you can see now this girl, or she's not a girl anymore, she's like adolescent or young adult. Timing of the puberty, when this will happen, normally around the 10 years onwards. And it will take how many years? 3 to 4 years. We can say that each stage will take 1 year, because as we mentioned, the puberty will start from stage 2, because stage 1, it's pre-pubertal. So from stage 2 to stage 5, it will take 3 to 4 years. It means that each stage can take 1 year. The lower end of the normal range will be around 8. So that's why any girl before 8, it's precocious puberty. Sometimes we have some ethnic changes or variations. So you will find that in the African people, the puberty may start a little bit early. So we can say it's to give the diagnosis of precocious puberty, it has to be before 7. But in this dog article, we will depend on 8, right? But in some ethnic groups, we can give another lower age for the puberty. In any girl, budding of the breast or thelarche, this is the first sign of the puberty. And it was like very famous questions in part 2 exam, if you remember, the questions about the puberty, when this will start, which one will happen first, or the first sign. And it was difficult questions at the time, as I remember. So breast budding or thelarche, this is the first sign of the puberty. Then it will followed by pupar, which is the development of the pubic hair. Then the axillary hair will start to develop. The growth, usually it will start with the onset of the puberty and the peak height velocity at the mid of the puberty. That's why if the patient will present with precocious puberty, usually she will continue with short stature, because she will have like early closure of the epiphyseal ends. Menarche, usually this will happen 2 to 3 years after the thelarche. So what about the first time, please? It's thelarche. Then puparche, then menarche, 2 to 3 years after the thelarche. And that's why the start of the puberty around the 10 years, and the median age here for the menarche, it will be around the 13 years, right? So this is the timing of the puberty. What about the sequence of events? Like which one will happen first? Budding of the breast, thelarche, then puparche. 2 to 3 years after the thelarche, the menarche will happen, and usually the median age will be 13 years. All of this, as you can see, we are speaking about the normal physiology. So it will be like introduction. After that, we can speak about the precocious puberty. In the exam, you can cover this introduction in 1 minute. It will not take time. But now, because I'm explaining like points for you and things, it will take time, or it takes time. But in the exam, you can finish the introduction, the definition with the introduction in 1 minute, and then go to the precocious puberty. As we mentioned, 3 types, or the classification. We can give 3 types here: central, or true, or gonadotrophin dependent; peripheral, pseudo, or gonadotrophin independent. And actually here, I love these terms. Why? Because it's description of really what happened. Central. So usually it will depend on the central nervous system, the hypothalamic problems, pituitary, and it's a true one because it starts from this axis. and it's dependent on the gonadotrophin. So it's simply description of what happened. Peripheral, so it's away from the brain. Pseudo, because it's not dependent on the gonadotrophin, and that's why it's gonadotrophin independent. Isolated variants like precocious, thelarche, puparche, menarche, one of them with normal other two features. Here you will find a very, very nice tables in this talk article, causes and how to assess any girl with the precocious puberty. And I kept it like that, exactly as it is from the talk article. You will find this is the whole table, and I split it here into 2 slides to be easy in reading. So causes of the premature sexual development or precocious puberty. We have the first type, which is central. It can be idiopathic. And the point here that around 74 of the girls, 74% will be idiopathic without any cause. However, it's grunty. No, we need to rule out any brain tumor, pituitary tumor, anything. It might be central nervous system pathology, like hypothalamic hamartoma. Hamartoma, it's not malignancy, it's not tumor, it's like benign. We can give it benign. It's not benign tumor, but it's a benign accumulation of the cells from the same origin. Like here, hypothalamic hamartoma, it would be from the hypothalamic tissue, the cells and tissue. So it's not different. And usually it cannot cause anything except if it's, for example, in the hypothalamus. So it can cause precocious puberty. Sometimes it can cause pain if it will make like pressure on any nerve or anything. The most common site, it's extra information here for all of you guys. For the hamartoma is the lung. So this is the most common site, but it can happen in the hypothalamus as well. It might be tumor of the hypothalamus or the pituitary. It might be congenital disorder like hydrocephalus. Here I put just, I'm highlighting one word. In the exam, you will not be able to memorize everything. So you can summarize this to the examiner by saying it can be idiopathic or central nervous system related. It might be hypothalamic disease or a tumor. It might be pituitary tumor. It might be congenital disorder like hydrocephalus. It might be acquired like irradiation, trauma, post-infection. It can be secondary to the peripheral precocious puberty. And I will come to this point, how it's secondary to peripheral and it will be central one. We will come to this point. So this is the first type. And also, what about the causes for that? It can be peripheral precocious puberty or variants like its isolated one. The peripheral, it might be ovarian cause, adrenal cause, or exogenous sex hormones. It can be a syndrome, what we name McCone-Albright syndrome, or it might be long-standing severe hypothyroidism. So for the ovarian causes, what about the causes here? It might be estrogen-secreting tumor like granulosa cell. It might be androgen-secreting Sertoli Leydig cell tumor. It can happen in girls. One question here, guys. Yes, it can happen. And that's why we have in the precocious puberty 2 types. It can be isosexual. So for example, she's a girl and she has estrogen secreting, or contrasexual or heterosexual. So she's a female, a girl, but she has androgen secreting. So she will start to have precocious puberty with some virilizing signs and symptoms. You got my point? So it's not in male or in boys. No, it can be in girls as well. It can be adrenal causes like congenital adrenal hyperplasia, Cushing syndrome, neoplasm of the adrenal gland. It might be exogenous sex hormone, like giving the young girl oral contraception. It has to be like a never event, but it can happen. Maybe there is contraception in the house and the girl, she's taking the pills, she's playing, So it can be like that. Skin cream, like for example, any lady using estrogen cream or even the testosterone cream. Anabolic steroid, the boys and going to gym. McCone-Albright syndrome, we will come to this. I put one slide because I know it's difficult to understand what is this syndrome. So I put one slide for it. And it might be hypothyroidism. And as we mentioned at the start in the summary or in the introduction, that the peripheral precocious puberty treatment will depend on the cause. So if it's a tumor resection or chemoradiotherapy, if it's exogenous sex hormones giving at the time, we need to stop. If it's McCone albright, so special treatment here. Hypothyroidism, replacement with the thyroxine. Simply treat the cause. It might be isolated or variants like Thilar, Minar, Pupar. And again here, I will come to each one how to manage. Okay, so these are the causes. In each one, we will have a special treatment, right? But in the central, it's the gonadotrophin mainly, and we will come in details to this point. What about the names and also how to use it? We will touch those points. In the investigations, we need to offer all the tests for all the causes, like if we are suspecting central or peripheral or isolated. But in the isolated, we will have some differences in the investigations. Let's go to the investigation. Generally speaking, how to evaluate a child with premature sexual development. Number one, history. Number two, examination. Number three, investigation, blood test, imaging, or any other modality of the investigation. So for the history, what about the age of onset, sequence of the events, which happen first? Is it the Thilar, is it the Minar, or the appearance of the hair, pupar? So we need to know the timing of the onset of the puberty in the mother and siblings. So for example here, guys, if we will face this scenario as simulated patient task in next exam, we can use the points here in our information gathering, which will be relevant questions by asking the mother, if the mother she's attendant with the girl, like, what about the time of the puberty or having the periods in yourself or any other daughter she has? Neurological symptoms, exogenous sex steroid exposure, for example, food, drugs, cosmetics. Some social history will be important. As I mentioned, in the adoption, you will find that precocious puberty is more common with the adopted girls and also any patient with child sexual abuse. For the examination, what I need to do for this young girl? What about the height and weight? Body mass index to be calculated. Tanner staging to be given clearly. This young girl, she's now in stage 3. She's now in stage 4. Neurological examination, including examination of the eyes, visual fields. Why? Because some of the tumors will affect the visual field. So we can not diagnose, but suspect that we have a problem here, especially in the pituitary, if we have problem with the vision. Skin lesions like cafe au lait spots, it's very common in the Albright syndrome. Abdominal examination for this young girl for any mass, any obvious lesion we can see. We can also offer examination of the genital or external genitalia. We can check for clitoromegaly, deepening of voice, hirsutism if you are suspecting androgen secreting tumors. So this is the history examination. What's after that? Investigations. We need to offer imaging and biochemical. Biochemical, it means blood or urine. We need to offer LH and FSH baseline, then to offer GnRH stimulation test, which is the gold standard diagnostic tool in the central especially. So very important point, and I will tell you how to offer this test. We can measure the estradiol and or testosterone levels. It will be very high in the peripheral one, okay, because it's not dependent on the gonadotrophin. So you will find estradiol or testosterone very high here. But in the central, is it high? No, it might be normal or high normal. Adrenal steroids like 17-hydroxyprogesterone, very important to diagnose the adrenal hyperplasia. Free thyroxine and TSH, thyroid stimulating hormone. Prolactin levels, sometimes you will find, for example, in the hypothyroidism, in the McCone albright syndrome or prolactinomas, it can be raised, right? Urinary steroid profile, it will give us an idea to differentiate between the adrenal hyperplasia and the adrenal tumors. So if you are suspecting adrenal disease, so we have to offer urinary steroid profile. For the imaging, what about the imaging? What about the imaging? I need to know how about the bone age by offering left wrist X-ray. This is number one. Cranial MRI or CT. If the MRI not available, so we need to offer CT. CT adrenals or any mass. Pelvic ultrasound. Why pelvic ultrasound? To check the size, the shape of the uterus, endometrial thickness or shadowing or shadows, ovarian morphology if we have any ovarian mass or cyst or anything, and also skeletal survey and bone scan. So this is the imaging. In the exam, how to summarize it to the examiner. So for this girl, after history examination, I need to offer her some blood test or urine test, biochemical investigation, and some imaging. For the biochemical investigation, blood test, I need to measure the FSH, LH, estrogen, testosterone, and I need to offer her very important test named GnRH stimulation test, plus 17-hydroxy progesterone, free thyroxine, TSH, so thyroid function, prolactin level, plus urine steroid profile. Done with the biochemical. Coming to the image, X-ray, CT, MRI, CT adrenal, pelvic ultrasound, and bone scan. For the central precocious puberty, usually it results from the premature activation of the hypothalamic pituitary gonadal axis, which is the normal process of the puberty. But what will happen? It will be premature activation, right? And usually it's isosexual. For the peripheral, it will not depend on the hypothalamic. So hypothalamic pituitary gonadal axis not involved. It can be iso or heterosexual or contrasexual. Okay, so here you can suspect, if it's a heterosexual, please suspect adrenal disease or androgen secreting tumor from the ovary, right? So here, two differences again, or difference here between the central and the peripheral precocious puberty. Now we are done with, generally speaking, about the precocious puberty. Coming to each special type, how to assess, what about the special test to offer, and also how to treat by the end. So central precocious puberty, 74% will be idiopathic without any cause. But is it guaranteed? No, we need to rule out any disease, any organic causes. And usually you'll find the organic one, or there is like underlying disease, higher in younger girl. For example, the girl is 6 years, so please suspect a disease, suspect a lesion in this very young age. And at the start, this young girl will start to have tall stature. We are comparing her to her like colleagues in the school, for example. So she will start to have tall stature more than them, and then accelerated bone maturation, premature epiphyseal fusion, then compromise final height. She will be short. This girl also will suffer from some psychological problems, altered self-image. So it's very important to offer them a counselor or psychologist. Please don't forget in the multidisciplinary team. Here you will find a very nice growth chart here showing the growth or the height of a girl with precocious puberty. So what will happen here, if you can see, here we have the years, 5 years, 6 years, 7. Usually the puberty has to start here from 8, after 8, and usually the median age will be around 10. So what will happen if this girl is short? Here she will start to increase her height to catch the normal height by the end. But here, because the height or the growth start early, around 5 to 6 years, you will find sudden increase. So if you will compare this girl here, she's, for example, here 7.5. You will find her taller than her colleagues in the school. But what will happen after that? Around the age of 8, her height will be steady or with just a minimal increase. That's why by the end, she will end with short stature, 155. Usually you will find them around the 150 centimeters. Okay, so this is the normal and this is the abnormal. And that's why she will end in short stature. What about the investigations of the central precocious puberty? We need to offer the bone age, and usually you will find it advanced and more than 2 years from her age, often by more than 2 years. Uterine volume, again, it will be more than the uterine volume in her age by 2 ml in the volume, or the length will be more than 34 millimeter. Baseline serum gonadotrophin may be raised. Estradiol level variable, not very reliable. Okay, in the central, but in the peripheral, yes, it will be higher than normal. Elevated prolactin level rarely seen in the girls with central precocious puberty, except if we have a tumor, for example, in the pituitary, and there is prolactinoma as well. MRI for the brain, and if it's not available, offer CT. So 6 tests here we need to offer. What about the gold standard here to diagnose? The gold standard test will be the GnRH stimulation test. How to do it? We have 1 or 2 slides about this test. We will give this younger GnRH analog bolus, right? And then measure FSH, LH after. What will happen? In healthy pubertal children, LH response exceed FSH. So if we will measure like LH over FSH, it should be more than 1. In the prepubertal children, right, and also in the thalar variant, FSH response will exceed the LH. So if it's LH to FSH to be less than 1, FSH is exceeding the LH. In case of the central precocious puberty, what will happen? You will find the pubertal pattern. Like this girl, she's in the puberty, starting the puberty now. You will find the LH and to FSH ratio more than 1. And the peak LH levels vary depending on specific assay used. However, the values more than 8 international units usually considered diagnostic for the central type. So again, what we will offer here, the gold standard test, another buzzword here. So as we mentioned, some buzzwords you have to tell in the exam. One of them will be the GnRH stimulation test. Give this young girl GnRH analogs, bolus, and then measure FSH, LH. What will happen in the pubertal children? LH response exceed the FSH. In the prepubertal, the reverse, FSH exceed LH. In the central precocious puberty, you will find the pubertal pattern or response with the LH to FSH ratio more than 1. LH peak will be more than 8 international units, which is usually diagnostic. How about the treatment here? How to treat the cases of the central? As we mentioned in the start, what about the mainstay here of the treatment will be gonadotrophin analogs, right? So the majority with no apparent cause is found. So that's why we cannot treat the cause. Because if we have lesion, for example, we need to resect. If we have hamartoma, conservative management. Idiopathic may not require treatment and just watchful observation. Observe. But what about the mainstay? As we mentioned, it will be the gonadotrophin releasing analogs. The goal of the treatment, why I will give this young girl gonadotrophin analogs? Why? We need to regress the secondary sexual characteristic, prevent early menarche. This young girl will not be able to take care of herself or to have the hygiene, the care during the period. So we need to prevent the early menarche. We need to retard the skeletal maturation to give her extra height by the end of her puberty, improve the final height, and avoid psychosocial behavioral sequelae. They found also those girls will be liable or at risk of the abuse or sexual abuse. She's young in age, but her body like mature as an adult. So that's why she will be at risk of any sexual assault or abuse. Gonadotrophin releasing hormone analogs. We mentioned this is the mainstay of the treatment. And we need to give continuous stimulation. And this will lead to at the start of stimulation and then down regulation. Because you might say the problem with the GnRH, so how to give her GnRH analogs here? Yes, at the start it will cause stimulation, then down regulation of the receptors, and it will reduce the gonadotrophin synthesis. We can give it like rapid acting or long acting depot preparation. So we have many ways. We have the long acting or even the short acting. We have the long acting given every 3 to 4 weeks or 10 to 12 weeks. And we have the short acting, which is given on daily basis. What about the treatment, the names, and how to give? If you wish to remember the names, yes, you can do that. But my advice, because in the exam, you will not be able to memorize all of this, give the examiner the tips. Like, for example, here, the long-acting preparation available. We can give it subcutaneous or intramuscular, and it can be given every 3 to 4 weeks. We have also long-acting depot to act or to be given every 10 to 12 weeks interval, full stop. So is it important? I put here the names, but is it important? If you can remember one name, that's good. If not, and this is my advice, give the general, because usually those medications will be prescribed by the endocrinologist. But just tell the examiner that you know that we have the long-acting preparations, and we have the implantable one, and we have the short-acting. Or the long-acting can be a depot, which we will give subcutaneous or IM, or we can give the implantable, and it's effective for 1 year. Right? Like history. Short-acting intranasal preparation. It's like a spray. So this spray given on daily basis. What about the problem with these medications? Less efficient and difficulties with compliance. It's on daily basis. So this young girl has to take it every day, every day. So if it's subcutaneous every 3 to 4 weeks, I think it's perfect, right? So here we have the different methods of giving or preparations of the gonadotrophin releasing hormone analogs. What about the adverse effects? Do you remember my advice? Another advice here, please note it down. With any medication, don't forget the side effects. With any surgery, don't forget the complications. The patient has the right to know what she will experience, what she will face. This for 2 reasons. She will be adherent to her medications. She's going to say, oh yeah, the doctor told me that I might have headache. So it's normal. But if you didn't tell her, she will stop the medication. You got my point? So adverse effect, it's very important in any, keep it in your practice. So keep it in your practice. So when you will go to the exam, it will be like your way. So I will give you this medication. It's considered safe. However, it can cause some problems with you, like having some headaches, having some hot flushes, mood swings, like to feel yourself down a little bit. You might have at the injection site some reactions like rash, bruising, which is like bluish discoloration, or to have abscess, trial abscess here, one of the complications or the adverse effect. So keep it in your mind with any patient. So here it's a structured discussion, but tell the examiner, I need to give the patient the adverse effects of this medication. Headache, hot flushes, mood swings, and reaction, injection site reaction. Long term may be linked after that to polycystic ovary. They found that long-term use of the GnRH analogs. It will affect the bone by any mean? No long-term sequelae on the bone. But just polycystic ovary might be like long-term sequelae. So those are the adverse effects. Then we will give the patient the medication and that's it. She will take it for life. No, we need to monitor the response and to tell the patient when to stop the medication. So suppressed LH response, do you know the gold standard test? The GnRH stimulation test? Do it. If we have suppressed LH response, now it's done. Now the treatment efficacy is monitored and there is response to the treatment. And when to stop? When the time to the normal puberty began. For example, you have the girl 7 years, she can take it till 10 or 11, 10 years and then stop. Because usually it will take time till the puberty will start, around 1 year or more than 1 year. It's around 16 months. Yeah, it's here, 16 months. Right? So when to stop? When it's the time of the normal puberty, 10 years. Decision to discontinue, you will not take it by yourself. Please remember in the exam, another tip here for the exam, shared decision. What is the meaning of shared decision? It has to be the consultant, you, and the patient. Here we do have the patient and her parents. So don't forget the child and her parents. So we have to ask this child, yes, Now, this is the start of your puberty. Is it okay to stop the medication? So we will allow your body to start the changes. Yes. So that the girl has to accept, and also the parents. And who else with you and the consultant? The endocrinologist. So this is the shared decision. And usually it will, this manifestation of the puberty will reappear within 16 months, right? So usually it will take few months till the normal mechanism will start, or the characteristic to reappear again. So this is all about the central precocious puberty, right? Do you have any questions till the point? I know it's difficult and long discussion today, but it's like, it's mandatory. And that's why even I choose to start with this difficult scenario, because it's not wise to keep it till like the end of the preparation, like just before the exam. Thank you, Dr. Ahmed. Thank you so much. Coming to the second type, the peripheral precocious puberty. So it's another name, gonadotrophin independent. It's caused mainly by the ovary or the adrenal. Relatively uncommon in girls, and it results from secretion of sex steroid. Causes, it might be ovarian, adrenal, like congenital adrenal hyperplasia or tumor. It can be McCone-Albright syndrome. So those are the causes. What about the McCone-Albright syndrome? It's genetic problem or mutation of one gene in the body. Is it important to remember or memorize the gene? No, at all. Usually, this young girl will present with abnormal bone cysts, cafe au lait spots, or hyperpigmented macules on the skin with irregular edges, and peripheral precocious puberty. Right? Premature menarche may be the first clinical sign in those girls. We mentioned that the first sign will be Thilark in the normal puberty, but in the peripheral one, especially in the McCone-Albright, usually the first sign will be the menarche. So this is just few words. It's not important in the exam, but I put it here because I know that you will go and search what is this syndrome. We studied this syndrome, very long time ago. So just to remind you. What about the investigations for any peripheral precocious puberty? The bone age usually advanced except in hypothyroidism. So we need to check the bone age again by X-ray. We mentioned the investigation at the start. So when you will tell the examiner bone age, we are done with that. Baseline FSH and LH, GnRH testing reveals relatively flat gonadotrophin response. Flat, because it's not dependent on the gonadotrophin, isn't it? But what is the characteristic thing here? The estradiol, very high levels, right? Especially with the ovarian cyst or granulosa cell tumor. Anything secreting the estrogen or the androgen, the testosterone. In the adrenal causes, we need to measure the serum 17-hydroxyprogesterone. Another androgens like DHA and DHS, it's very important. And this one is characteristic. We will come to this point. So another androgen or adrenal androgen, if you cannot remember the names, or just give the abbreviation, no problem here, because we are in structured discussion. The examiner is aware about DHA and DHS, right? So serum 17-hydroxyprogesterone is very important to rule out any adrenal cause. 17-hydroxyprogesterone level elevated in the adrenal causes because we have defect in one enzyme, especially in the classic congenital adrenal hyperplasia, and occasionally in the adrenal tumors. But if it's very high, at that time, you have to suspect the congenital adrenal hyperplasia. DHS, it's produced from adrenals, and it's marker for the androgen-producing tumors. So that's why it's one of the important enzymes to measure. Important markers to measure. Urinary steroid, very important. Why? It can be very high in the adrenal tumors. So once you will find this one higher than normal and DHS higher than normal, go to the urinary 17-ketosteroid. It's higher in the adrenal tumors. It's one of the tests you will differentiate between the adrenal hyperplasia and the adrenal tumor. So that's why if the serum level indicating adrenal disease, please offer urinary steroid assessment, especially the urinary 17 ketosteroid, right? It will be very high in the adrenal tumors. Thyroid function, is it important? Yes, because one of the causes of the peripheral will be the thyroid disease, hypothyroidism, severe and prolonged one. Serum prolactin, is it important? It might be increased in the girls with McCann-Albright syndrome. So again, the prolactin is important to be measured. Treatment. And here I kept it as the TOG article, just to make it clear for everyone. Treatment of the peripheral equal treatment of the cause. So for example, if it's a hypothyroidism, how to manage? Give thyroxine. If it's exogenous source of steroid in food, medications, cosmetics, please discontinue the source of the sex steroid. If it's a classic form of the congenital adrenal hyperplasia, we can manage with the glucocorticoid. If it's non-classical congenital adrenal hyperplasia, we can treat with the hydrocortisone. Adrenal ovarian tumor, surgical treatment, chemotherapy, radiotherapy, depending on what about the nature of the tumor, the stage. So it's just treatment of the tumor. Mainly will be the surgical removal. Okay, so this is the adrenal and ovarian tumors. If it's Albright syndrome, suppression of the gonadal stridiogenesis with aromatase inhibitor. In the introduction at the start, we mentioned we might need to give aromatase inhibitor. So what is aromatase inhibitor? It will suppress the gonadal steroidogenesis. It can be secondary central precocious puberty. How it's peripheral and how it's secondary central. So it's following prolonged steroid exposure. And at the time, we need here, although it's peripheral, but it's peripheral and leading to central after that because of the prolonged exposure to the steroid, at that time, give GnRH analog therapy as the central one. Right, guys? So simply in the peripheral, if you cannot remember all of this, just please tell the examiner. Treatment will be treatment of the cause. And give like 2-3 examples. Hypothyroidism, McCann-Albright, if it's a classic form of the congenital adrenal hyperplasia, if it's exogenous source of the steroid. So here, give one example how to treat. One example how to treat. 2 to 3 examples will be more than enough in the exam. Because the idea now, the examiner knows that how to assess the girl, how to reach, is it central, peripheral, or isolated, and how to manage as well, right? So this is the treatment. Other drugs we can use in the peripheral, yes, we can give, for example, some of the progesterone, like medroxyprogesterone. It will suppress the gonadotrophin release and block the gonadal steroidogenesis as well. We can give selective estrogen receptor like tamoxifen, which we used in the breast cancer. How we will use it or why? It will block the estrogen receptor. So it will stop the effect of the estrogen on that girl. We can give some of the antifungal like ketoconazole. It will block some enzymes in the steroid biosynthesis. We can give anti-androgen like spironolactone. It will compete with the testosterone for its receptors. So another medications. And my advice, if you cannot remember, I don't want to bother you today and make it like challenging, but if you cannot remember, just as I mentioned, treatment of the peripheral will be treatment of the cause. If you can remember 1 or 2 examples here, like medroxyprogesterone, tamoxifen, now you are excellent. Okay. Now we are done with the peripheral one. Coming to the isolated or the variants, like premature Thelarche alone, Menarche alone, or PPAR. So if it's Thelarche, so it's premature breast development, it might be unilateral or bilateral, and it happened in absence of any other signs. So there is no pubic hair, there is no periods, there is no menarche, or there is no axillary hair. It's just the breast development. So in most girls, the puberty will start on the usual time, which is 10 years. And final height here will be normal. Why? Because it's just isolated thing that her breast starts to develop, but there is no problem with the hormones, and the final height will be normal. It's not dependent on the gonadotrophin, and it will accelerate the closure of the bones. But it's not a guarantee. 14% of those girls will develop central precocious puberty. So if the girl or the mother will come to you and saying, now my young daughter, she's 6 years, and I noticed that there is breast budding, don't reassure. Yeah, we have to reassure. However, keep an eye on that girl. Why? Because of the central precocious puberty. Investigations, it's not needed in any mild cases. However, if it's like moderate to severe cases of the breast development at that time, so for example, if the girl showing stage 3, 4 in the breast development, at the time we need to offer the investigations like baseline gonadotrophin, estradiol level, and usually they will be within the normal pre-pubertal range, because it's isolated thing. It's just one error in the breast development. You know, it's not dependent on any hormone like gonadotrophin or the estrogen. RH, which is the GnRH stimulation test, may show some FSH predominant response, which is coming with the prepubertal response. So again, it's normal. Pelvic ultrasound, uterine dimension appropriate to age. So any problem with the uterus, with the ovary? No. We might find like microcyst in the ovary, but lesion like a granulosa cell or estrogen secreting tumor, no, we will not find. What about the treatment? Reassure, but don't leave the girl. Careful follow-up every 6 months. Full stop. Now, we will consider it normal. However, we need to keep an eye on this girl for a while until her puberty will start. And this visit has to be every 6 months, just to rule out this young girl will not go into central precocious puberty. What about the menarche? The menarche, it can be just bleeding, spotting, or cycles, periods, every month. So it's uterine bleeding occurs in the young girl without other signs of secondary sexual development. The bleeding might be isolated bleed to regular monthly cycles. So is it like one presentation? No, it can be different from one girl to another. Normal pubertal development include menarche occur at the same time as other girls, which is the 10 years. 10 years for the puberty and 13 for the menarche. But this is premature menarche. It's not necessary to be like cycles. So it might be like sporadic bleeding. That's why here they mentioned that the puberty, including the menarche, will start as normal. What is the cause? Why this young girl start to have bleeding? So there is a theory. There is no clear cause for that, but there is a theory that there is increased sensitivity of the endometrium to the estrogen. The circulating estrogen, the endometrium is sensitive to it, but it's not enough to develop other sexual characteristics like breast development. It might be the cause. Bone age will be affected? No, because it's not dependent on the hormones. Pelvic ultrasound will show normal uterus with no endometrial shadow. But the endometrium is sensitive to the estrogen. That's why this young girl will start to bleed. Sporadic bleeding up to regular monthly cycles. No long-term sequelae in the isolated premature menarche. No treatment is necessary, but the child should be kept under follow-up. So the isolated, you will see that just follow up this girl until we will see it's just isolated or we will have any other problems. What about the adrenarche or pupar? So now the adrenal will start to work. Usually it's before the process of the puberty, like it will start around 6 to 8 years. Sometimes it might happen before that. Secreting those androgen will lead to the pubic hair and also the axillary hair. So it's precocious secretion of androgen, and usually this girl will present with axillary hair, adult body odor, spots, greasy hair, skin, and mood swings. There will be increased growth velocity and slight advancement of the bone age. If you remember in the menarche We mentioned that bone age will not be advanced, will not be affected. Here, because it's androgen dependent, so slight, but it's not like the central one. Slight advancement of the bone age. Final height and onset and progression of the puberty will not be affected. Elevation of the serum DHA to range found normally in early puberty is characteristic, right? Although other steroid hormone levels will be normal, right? Sex hormone levels, it's in the pre-pubertal range. GnRH test, pre-pubertal pattern. In more severe cases of the non-classical congenital adrenal hyperplasia, it might be just presented with the adrenal. So we need to rule it out. Okay, guys? So here, what about the assessment? Again, the same assessment. You will not find anything, just a little bit increase in the DHA to the like upper limits of the normal values, but other hormones normal. Everything will be normal. The sex hormone, the GnRH test, stimulation test, everything will be normal. But keep in mind the non-classical congenital adrenal hyperplasia. We need to rule it out. So this is the isolated pattern. By the end, you'll find it's a very nice but complicated algorithm. I kept here, it's like, you know, like a summary for all what we discussed. To understand that this algorithm, you have to have like deep understanding of the previous slides. So let's go just arm by arm. It will be helpful by the end of your preparation. If you are preparing this case, you can go with this algorithm to know how to navigate during like assessment of the girl with any precocious puberty. So do the history, take the history and do the examination and check if this young girl has only Thylarch or Menarche only. Assess the growth velocity and the bone age. If we have rapid growth rate and advanced bone age at the time, no, we need to measure the FSH, LH, GnRH test. If we have raised FSH, LH, pubertal response, so at that time, give the diagnosis of the central precocious puberty. And don't forget to offer cranial MRI or CT. If it's normal, consider GnRH analogs. It's idiopathic type. If it's abnormal, manage according to the cause. If we have low FSH, LH response or flat response, we can give the diagnosis of peripheral one, especially if we have, for example, high estrogen level. Offer abdominal pelvic ultrasound. If it's normal, assess for and remove exogenous estrogen source or androgen. If it's abnormal, treat according to the cause: adrenal disease, tumor, ovarian cyst, ovarian disease, ovarian mass, to manage accordingly. If we have the Thylarch and Menarche, and we have normal growth rate, no advanced bone age at the time. What about the Thylarch? Observe, it's isolated one, observe every 6 months. See the patient every 6 months. If we have Menarche, offer pelvic ultrasound to check what about the uterus, the endometrium, and the ovary. If it's isolated, again, reassure and observation. If we have in the history premature sexual hair development, which is the pupar, assess again the growth, bone age, measurement of the serum androgen. If we have normal or slight increase in the growth, advanced bone age, serum androgen, like more than the normal, at the time it's isolated premature adrenarche. Again, reassure, observe this young girl. If we have rapid growth, advanced bone age, at the time measure 17-hydroxyprogesterone. If it's higher than normal, gives the diagnosis of congenital adrenal hyperplasia. And here it will be the endocrinologist management at that time. If we have the DHS more higher than normal, here it's a little bit raised or upper normal level, like it's you know, the high level of the normal range. So here we can give the isolated, but here you will find it like it's more than normal, massive increase in the DHS. At the time, suspect adrenal tumors and offer surgical treatment. You guys, as I told you, it's a little bit complicated, but with good understanding from the previous slides, we can go smoothly between the arms here. It's just to navigate you how to assess the girl and how to go through the case. Any questions? When to stop? Yes, Dr. Adina. You have to stop at the start of the puberty. So it's around 10 years. So you will start this patient on GnRH analogs now, and you have to stop by the normal age of the, or the median age of the puberty, which is 10 years. What point of 16 months? Usually that we will stop at the age of the puberty, as I mentioned, okay, the normal one. And we have to give time for the secondary sexual characteristic and the puberty to start. Usually it will start after few months, and you will find the menor, especially the menor, will start within 16 months. So it's more than 1 year for this girl to her body to come back to normal, you know, after stopping the GnRH analogs. You're welcome, Dr. Dina. Thank you so much. Thank you so much, Dr. Sima. Thank you, Dr. Ahmed. Any other questions? You're welcome, my dear Shaista. I'm very happy that you are here today. Thank you so much. Thank you so much, my dear Tengi. Thank you so much, Tasabih. You are welcome. You're welcome, Mahmouda. Thank you so much. So that's all for today. If you need any questions, you can drop the message on the groups, either the case discussion or the study group, for any point regarding the precocious puberty. I will upload this video, inshallah, on the YouTube, and I will share the link, and I will try to put this slides, because it's just like a summary for this topic. I will try to put like the link on the YouTube as well with the same video. So just press on the link. I will make it like open for everyone, so you can have the access to those slides as well. Okay, and again, if you have any questions regarding this topic or any other topic, please just drop a message. Okay, you're welcome, my dear Monica. Thank you so much, my dear. All right, guys. Thank you so much for your nice attendance, and I wish it's now clear and easy for everyone. And see you soon, inshallah. Assalamu alaikum wa rahmatullah. You're welcome, my dear Grace. Thank you so much. Assalamu alaikum wa rahmatullah.